Medic 113, respond code 3 for the 35-year-old male, unknown medical order residence.
Scenario-based learning.
Scene size up.
I have my BSI on. Hey Vito, don't forget your gloves this time. Another unknown problem call. Do you think the scene is safe?
Come quick! I found my brother in the bathroom. He's down on the floor. I can't tell if he's breathing.
What's his name?
Ryan.
Okay, sounds like we have one patient. Sounds serious, so I'm going to request ALS backup.
Copy, Medic 113. Backup is on the way.
Primary survey.
Hey partner, take spinal motion restriction until we get more information on what happened. Hey Brian, can you hear me? No response to verbal. I'm gonna see if he responds to pain with a sternal rub. No response. Brian is unresponsive. I am checking his airway now. Nothing in the mouth. Do you hear those snoring sounds, Vito? His breathing rate seems a little slow, and that tidal volume is really low. He has a weak pulse. His skin is pale, clammy, and Vito, look at that cyanosis around his lips. Also, I don't see him bleeding from anywhere. Vito, grab a quick set of vitals while I auscultate his lungs. Lungs are clear, equal, and diminished in all fields. Scoot that house bag over here. We have some things to get done. And Vito, go get the sister. We need more information about Brian. Remember, the primary assessment is all about finding and fixing life threats. These life threats generally occur within the ABCs, so now it's up to you. Tell me what were the life threats found, if any, and what you plan to do about fixing them. If the snoring respirations got your attention right away, then you nailed the first one. Remember, the most common obstruction we find in the airway is the tongue, especially in unresponsive supine patients. Now, how do we fix this? Start with the basics. Manual airway positioning. New AHA guidelines for 2026 move away from using the jaw thrust in trauma if it's unsuccessful the first attempt. Go right for the head tilt chin lift. Without a patent airway, nothing else matters. If your patient doesn't have a gag reflex, insert an appropriately sized OPA. If the gag reflex is present, use an appropriately sized NPA. I hope you don't think you're finished yet. Find anything else that needs immediate fixing? How about that shallow breathing? Remember, breathing has more than one part. Both the rate and the tidal volume must be adequate. Use all your senses to assess the work of breathing. Well, maybe not taste. That would just be weird. So look, listen, and feel to help you assess breathing. Now, what are you going to do about it? If you said non-rebreather at 15 liters per minute, you may need to hit the books a little harder, or maybe a lot harder. There's only one answer. Anytime you determine your patient's breathing is inadequate. Everybody say it with me. Bag valve mask with 10 to 15 liters per minute of oxygen hooked to it. Remember to only ventilate until you see the chest rise and keep your rate at 1 breath every 5 to 6 seconds. Brian's gag reflex is still intact, so we had to use an NPA.
History taking.
Now that we have addressed the immediate threats to life, we can turn our attention to piecing together what happened and what's wrong with our patient. History taking is best done by conversing directly with the patient. Obviously, in this case, that's impossible, so we will try to obtain as much information as we can from his sister. The easiest way to remember and structure how to get essential patient history and details of what happened is to use the acronym SAMPLE. Each letter stands for a different component of the patient's history. S, signs and symptoms. Remember, signs are things you can see or measure. Symptoms are verbalized complaints. What do we know about the S for Brian? Brian's primary sign or chief complaint is being unresponsive. Another would be respiratory failure. Remember, these are signs, not symptoms, because we can see them actually happening. We will use another acronym to help us remember to ask important details about the signs and symptoms. OPQRST should always be used for this purpose. But remember, some letters can be skipped if they don't make sense to use. You will see this when we talk to Brian's sister. Onset. Did this seem to come on suddenly or gradually?
We were talking in the kitchen 5 minutes before I found him. He seemed fine. I have been worried about him lately, though. He struggles with back problems from an old work injury.
PQ and R don't really apply to this situation, but are perfect questions for things like the symptom of pain. So if Brian comes around and complains of pain, we will swing back around to these. Severity. Has this ever happened before? And if so, was it this severe? This can also be where you introduce a pain scale if it makes sense.
Yes, this exact same thing happened about 6 months ago. The medics came and gave him some medicine and he woke up. They said he took too much of something. I can't remember what. But Brian denied it when he woke up.
T. Time. How long has this been going on? Did you call as soon as you found him? Time and onset get confused often. Remember, onset is how quickly did the condition come on. Time is how long total the condition has been present.
I called right away. This had to have happened right before I found him.
Ma'am, is there anything else you know of that's been going on with Brian?
No, nothing. He is a very private person and seemed completely fine earlier today.
Okay, let's keep our sample history rolling. Allergies. Does Brian have any allergies to any medications?
I think he said he is allergic to ibuprofen.
M. Medications. Does Brian take any medications?
I know he sometimes takes pain medication for his back and something for anxiety, but I don't know the names.
This is why it's important to be familiar with common prescription and over-the-counter meds when working as an EMT, especially knowing the different classes of medications. Can you see the picture that's emerging about what's going on with Brian? P. Pertinent past medical history.
He has never mentioned anything else.
Remember, we only want pertinent information and major medical issues. Some patients want to tell you their entire life story. L. Last oral intake. Last known well. So the last time you saw him well was a few minutes before he went into the bathroom, correct? And do you know by chance when the last time he ate was?
Yes, he was well about 15 minutes before I found him. Nope, I'm sorry, I don't know when he ate last.
E. Events leading up. We already got this information during the course of our history taking. This can be very important information and can really help you understand the whole picture. The secondary assessment has us looking deeper into the specific body systems that we think are affected or causing Brian's condition. We will also at this time perform any other interventions or treatments allowed by our protocol for Brian's condition. Now you make the call. What systems need assessed further and how is that assessment performed? I will give you a hint. We have already knocked out most of 2 systems already. So an easy way to think about secondary assessment is to automatically include the circulatory and respiratory system for every patient. We have already assessed the most vital parts of both systems. So now add in the neurologic system and psych/social considerations for this specific patient condition, and we can complete our assessment hitting all the appropriate bases. If any additional life threats are found during the secondary assessment, treat them immediately. All non-life threat issues/injuries should be noted and dealt with as time allows. Here is an example of some specific things to assess with these systems. Starting at the head, we need to assess the pupils. They can tell you a lot about issues in the nervous system. We are checking them with a small light to see if both pupils are equal and reactive to light. We call that pearl. Checking the neck for jugular vein distension or JVD. The presence of this points to possible issues with the circulatory or respiratory system. While examining the neck, also check the position of the trachea. It should not be deviated to the left or right of the midline. Moving to the chest is time to auscultate the lungs. Remember to listen to both apex first and then both bases to compare what you hear from lung to lung. Also look for any abnormalities or asymmetrical chest wall movement. Okay, now that we have the life threat stabilized and enough history and assessment, we need to decide what we think is wrong with Brian and get some treatment done. So, now you make the call. What's your field impression and what treatment/diagnostic testing remain? Okay, time's up. Let's see if we are on the same page. If you said overdose, then we are in line with our thinking. Now, what could he have taken? Prescription meds? Street drugs? Mixture? That we don't know. But our next moves should be crystal clear. What is your plan? Now let's get to work. Vito, grab me a fingerstick blood glucose level while I get the Narcan ready. I'm gonna give him 2 milligrams intranasally. Let's also get an end-tidal CO2 reading since his breathing was affected. It can also help us stick to a good ventilation rate, keeping the number between 35 and 45. BGL 102? Thanks, Vito. That rules out hypoglycemia. Narcan is in. We can give him another 2 milligrams in a few minutes if he doesn't come around. But remember, if he didn't overdose on an opioid or opiate, then Narcan won't work. We will then have to think about a more advanced airway. Where the heck is that ALS backup? Brian's eyes are equal and reactive, but also constricted. Vito, look, he's starting to move around. Brian, can you hear me? There you go, man. Relax. You're okay. We are EMTs, and we are here to help you.
What the heck happened?
Your sister found you on the floor here in the bathroom. You were barely breathing and unconscious. Reassessment is a very important part of our patient encounter. We need to track trends in vital signs and also have a structured way to know if our patient is getting better or worse. Don't overthink it. Redo your primary assessment, vital signs, and check your interventions. If time permits, redo the secondary assessment. For unstable patients, this should be done every 5 minutes. In reality, we are constantly monitoring the patient's ABCs. By the way, cancel that ALS backup.
Copy that 113.
When it comes to vital signs, always get your first BP manually. After that, if you have a cardiac monitor that can do it automatically, it allows you to set up BP and pulse ox checks, done automatically at whatever interval you set. Remember, for unstable patients, reassess every 5 minutes. For stable patients, every 15 minutes. Don't get complacent. Airway, breathing, and circulation must be constantly monitored during the entire patient encounter. Okay, Brian, you're doing a lot better. Your airway is nice and clear. Breathing is much better. We put you on a little oxygen via a nasal cannula because your oxygen levels were a little low when you woke up. Your pulse is nice and strong and within normal rate. Your vitals all look good. How are you feeling?
I'm feeling okay, just a little tired and embarrassed.
Brian, that's completely understandable. The important thing is that you are going to be okay. Your sister saved your life today. There is help available for you to make sure this never happens again. I hope you accept that help. Now just sit back and try to relax. I'm going to call the hospital and let them know we are coming.
Mercy Health Youngstown. Go ahead with your report.
Good evening, Mercy Health. This is Youngstown Medic 113 en route to your facility with a 35-year-old male patient unintentional narcotic overdose. Patient took an unknown pill from a friend approximately 20 minutes before symptoms presented. Patient was initially found unresponsive with snoring, shallow breathing. We assisted ventilations with bag valve mask and administered 2 milligrams Narcan intranasally. Patient woke up to some confusion but has come around to alert and oriented ×3. We currently have him on O2 at 2 liters per minute and vitals all within normal limits. His BGL is 102 and currently only complaining of being tired. We have an ETA to your facility of approximately 5 minutes on the green.
Copy that 113. We shall see you upon arrival.
So there you have it. This assessment lines up with the State of Ohio EMT practical skill. If you learn best through scenario-based and visual material, then you're in the right place. Make sure to like this video and subscribe to our page so you can be a part of the most up-to-date fire and EMS training in the country. Thanks for watching.